All right, so it's my pleasure to introduce Dr. Amanda Lindo. I was going through your CV and I realized we've known each other for almost 7 years. We started off when you were a fellow, a resident in internal medicine at Norwalk Hospital. Before that, obviously, you attended medical school at Ross. And you finished your internal medicine residency, and we were very fortunate enough to keep you at Norwalk Hospital for your pulmonary and critical care fellowship that was done at Yale. And then I was able to get you to come back again for the 7th and final year of your sleep medicine training. And very happy to know that you're going to be continuing on with clinical practice in Erie, Pennsylvania, at the Allegheny Health Network, St. Vincent's Hospital, doing pulmonary critical care and sleep medicine, saving the world one patient at a time. So that's fantastic. And so happy that I got to know you during this time, and you're just an amazing, talented person. And we're very excited for your talk. So you'll be discussing about population health. So without further ado, Dr. Amanda Lindo. Thanks, everyone.
Thank you so much for that introduction, Dr. Weir. My name is Amanda, and I'm one of the sleep fellows at Norwalk Hospital. I will be talking about sleep health and disparities within sleep medicine. So this is the disclosure slide. I don't have any disclosures, and the CME code is 40560, and that'll be posted in the chat. So last week was actually National Sleep Awareness Week, and in honor of that, I decided to talk about sleep health and some of the disparities that we see within it. It's a little bit of an overwhelming topic, so please bear with me as I try and break it down into something manageable. So for a general overview, together we're going to learn exactly what the term sleep health means, and then we will review the current sleep recommendations that come from societies like AASM, Sleep Research Society, and the National Sleep Foundation. Then we'll get into sleep health at the individual and population levels with an emphasis on the disparities we see within sleep. And then we'll look into some of the sleep health disparities within common sleep conditions like insufficient sleep, insomnia, and sleep apnea. And then finally, we'll explore some of the potential interventions to improve sleep health at the population level and possible ways that we can mitigate some of these sleep health disparities. So what is sleep health? I think everyone can agree that sleep is crucial to our overall health and well-being. It's estimated that we sleep for about a third of our life, or we're attempting to sleep during that time. Yet for most of its history, the field of sleep medicine has focused its efforts mainly on the identification and treatment of sleep disorders. It wasn't until the early 2000s that sleep health really first emerged in the literature and in the media. It started being talked about within journals that focused on population health, public health, and preventative medicine. It wasn't until 2015 that the National Sleep Foundation launched the Sleep Health Journal, which is a peer-reviewed journal that specifically explores the role of sleep within population health. And since then, the research in sleep health has grown rather exponentially. But still to this day, sleep health is rather difficult to define. One definition that I found in my research that I quite like goes like this. Sleep health is a multidimensional pattern of sleep wakefulness adapted to the individual, social, and environmental demands that promotes physical and mental well-being. Good sleep health is characterized by subjective satisfaction, appropriate timing, adequate duration, high efficiency, and sustained alertness during waking hours. So in the simplest sense, sleep health refers to consistently getting enough sleep at the appropriate times that is of good enough quality to wake up feeling rested and alert in order to promote one's overall physical and mental well-being. Sleep health is not merely the absence of disease, meaning that just because one doesn't have a diagnosis of something like sleep apnea or insomnia doesn't mean that they necessarily have optimal sleep health. The metrics that we're interested in when we think about sleep health include things like sleep duration, so the total amount of sleep that's obtained per 24-hour period, sleep efficiency and continuity, which is the ease of falling asleep and staying asleep, sleep timing, which refers to how well one's sleep is synchronized to their circadian clock, sleep regularity, which is the ability to maintain consistent sleep schedules over multiple days, daytime alertness, which is how attentive and wakeful one is during the day, and then overall satisfaction, so someone's subjective assessment of good or poor sleep. So this is a nice framework that's giving an overview of how sleep health affects the individual. This model is showing how those sleep dimensions that I just mentioned, shown in the red box, can potentially affect a person's distal health outcomes, which is shown in that dark blue box. The model is suggesting that suboptimal sleep can inflict changes at like the molecular and cellular signaling levels, which can then cause things like inflammation and sympathetic activation, and that can ultimately impact health and causes of disease. At the bottom there, we see those arrows that are looping back into the sleep dimensions, implying that there's bidirectionality and a positive feedback loop at play. And so things like inflammation, sympathetic activation, and disease processes can further disrupt sleep. So now that we understand a little bit about what sleep health is, the next point to recognize are the disparities within it. We now realize that there are many inequities observed within sleep health that actually parallel that of other socioeconomic, and racial disparities that are seen within other health outcomes. Sleep disparities in particular are now being recognized as a very important contributor to disparities in overall health and in disadvantaged populations. These disparities stem from both socio-demographic factors like race, ethnicity, immigration status, and socioeconomic factors like employment status, education level, access to healthcare, and health insurance. Understanding and identifying the causes of sleep health disparities is our first step in being able to work towards potential solutions. So how do we tie this all together at a population level? At the center of these diagrams, we see the individual and the sleep health dimensions and their overall well-being. When we branch out from there, we're looking at these various social factors, again, the things like demographics and socioeconomic status, also things like family dynamics and belief systems, and then neighborhoods and external environments. And all of those have the potential to affect one's sleep health and create some of the disparities. At an even broader level, there are also societal factors, things like government policy, regulations and incentives, cultural and religious leadership that can affect sleep health of large populations. So when we think about the individual level in sleep health, let's sort of review what's recommended. So how much sleep should one be getting? In 2015, AASM and the Sleep Research Society released a joint consensus outlining recommendations for appropriate sleep durations through each stage of life. For adults aged 18 and up, typically 7 to 9 hours of sleep per night is recommended in order to support optimal health. They found that sleeping less than 6 hours or sleeping more than 9 to 10 hours was not recommended, but they were unable to reach a consensus on what might happen when one sleeps between 6 to 7 hours based on available data. So going through some of that data, so what happens when we don't get enough sleep? So there has been a lot about the health implications of short sleep duration. Some of the strongest data comes from a 2011 meta-analysis that looked at the cardiovascular outcomes in those who have self-reported short sleep duration of 6 hours or less. They found that those individuals with short sleep had significant associations with regards to increased risk of developing coronary disease and developing stroke. That study was mostly based on self-reported short to sleep duration, and there were follow-up studies that later validated the same findings, but did use objective measures for sleep duration, things like actigraphy and PSG data. The underlying pathogenesis that might link things like sleep deficiency and cardiovascular outcomes may be in relation to those changes in cellular metabolism, activation of low-grade inflammation, and activation of the sympathetic nervous system. Additional studies have looked at short sleep duration and linked it to impaired cognition, increased fall risk, impaired physical function, weight gain, and obesity. One meta-analysis from 2008 actually found a 55% increased odds ratio of developing obesity in those who had short sleep duration less than 6 hours. The reason behind this is pretty interesting and likely multifactorial. One thought is that if you're sleeping less, that means that you might have more time to eat in a day, which is certainly true, or that people are eating at inappropriate times relative to their circadian phase, which would promote weight gain. There's also evidence that shows that changes in the cellular metabolism with short sleep duration can lead to things like insulin resistance and impaired glucose regulation. That might be due to sympathetic activation, which has actually been shown to cause damage to beta cells in the pancreas, seen in some animal studies. There's also the thought that the higher ghrelin levels and lower leptin levels that we can see in sleep deprivation can lead to people choosing higher caloric foods and larger portion sizes. So really, there are a lot of health implications in those with short sleep duration. Moving on to the other end of the spectrum, what happens with long sleep duration? So somewhat surprising, meta-analysis have also found similarly increased risks of cardiovascular disease in those with long sleep duration, specifically increased risks of coronary disease, stroke, and cardiovascular events. Other smaller studies have also linked obesity and development of type 2 diabetes to long sleep duration. The mechanism of these is not as well understood. It's been suggested that perhaps long sleep is actually a marker of other comorbidities like depression or unemployment status, low socioeconomic status, or overall low physical activity, and that the long sleep in and of itself might not actually be causative of the cardiovascular associations, although the jury is still out on this. So another question is what happens in those who have an irregular sleep schedule, but they have normal sleep duration. So data from the National Health Interview Survey found that 70% of US adults report irregular sleep schedules. A lot of this is probably because of social jet lag, which refers to the concept that the school and work responsibilities dictate our wake times, and that might not align with one's chronotype or circadian preference. This would lead to reduced sleep on the work days and attempts of catch-up sleep and longer sleep duration on non-work days. Another consideration could be shift work. And it's estimated that about 25% of the US workforce is employed in a job that requires some form of shift work, so it's highly prevalent. One interesting study out of Brigham and Women's looked at irregular sleep patterns and cardiometabolic outcomes. They used existing data from the MESA-sleep cohort and found that for every 1 hour increase in sleep duration standard deviation or sleep onset timing standard deviation, there was about a 25% higher odds of metabolic syndrome. And so increased variability in sleep duration and sleep timing is associated with metabolic dysregulation, and that was independent of the sleep duration and independent of their obesity and BMI status. So not only does it matter for how long we're sleeping, but the consistency is really important as well. So now, not only does the quality of sleep impact cardiovascular and metabolic health, but it also heavily impacts one's mental health. There are so many sleep disturbances that we see that are associated with mental health conditions. Depression certainly can increase one's sleepiness, fatigue, and create a long sleep duration, while bipolar, mania, and schizophrenia can all manifest as acute sleep deprivation. Historically, sleep disturbances were such a common occurrence in mental health conditions that the traditional thinking was that the sleep disturbances were merely this epiphenomenon or a symptom of the mental health condition. And while that's definitely true, it turns out that the relationship between mental health and sleep is more complex than that. There's growing evidence that the bidirectionality between sleep and mental health, meaning that there's mental health conditions that certainly can cause sleep disturbances, but there's also sleep disturbances that can precipitate mental health conditions. To support that theory, some of the strongest evidence for the complex bidirectionality of sleep and mental health comes from a large meta-analysis of 35 prospective cohort studies. They looked at patients who either had initiation or maintenance insomnia at baseline, and they were looking at depression as their outcome of interest. They measured depression by self-reported questionnaires and/or clinician diagnosis. What they found was pretty interesting. The insomnia symptoms were significantly predictive of subsequent development of depression. There were also follow-up smaller studies that showed similar associations of insomnia symptoms being predictive for future development of other mental health conditions like generalized anxiety, bipolar, and PTSD. Building even further on that link between sleep and mental health, is that if the sleep disturbances are not adequately addressed, then patients are actually more likely to experience treatment failure in their mental health. There was this study that looked at both subjective and objective measures of insomnia as a predictor of treatment failure for depression. They took patients with major depressive disorder who were on maximal medical and behavioral therapy, and then they measured subjective insomnia scores and obtained PSG data for them. They were interested to see whether the combination of the insomnia symptoms combined with objective sleep disturbance on the PSG would potentiate the risk of relapse. They defined remission versus relapse based on the depression severity scores. What they found was that patients with untreated insomnia symptoms and objective sleep disturbances, specifically they were looking at a sleep onset latency of more than 30 minutes or a total sleep time of under 6 hours, those people were more likely to experience relapse in their depression despite otherwise optimal treatment. So the combination of insomnia symptoms and objective sleep disturbances did indeed potentiate that risk. So now that we know about the impact of inadequate sleep health, what's kind of going on in the US right now. So how many adults are actually adhering to sleep recommendations? In 2014, the National Sleep Foundation launched something called the Sleep Health Index, which is an annual general population poll that tracks America's sleep behaviors and trends. They found that nearly half of adults, about 45%, are not getting the recommended amount of sleep per night. Well, also noted that over the last several decades, the average sleep duration across the US has decreased by about 1.5 to 2 hours per night, leading to this epidemic of sleep deprivation where many adults are only in bed for 5 or 6 hours per night on a regular basis. The trend of short sleep duration is significantly more pronounced among minorities, especially the Black population. And subsequent epidemiologic studies have shown also poor quality sleep, delayed sleep onset, and increased sleep fragmentation among minorities and those of low socioeconomic status. There's been a lot of research as to why those minorities and those of low socioeconomic status might have significantly worse sleep health, and the data on this is really interesting. One contributor seems to be the type of employment that people have. As I mentioned before, about 25% of the US workforce is involved in a job that requires some form of shift work, and that irregular sleep schedules are linked to things like increased risk of metabolic syndrome. So this is data from the 2006 American Community Survey, and it's showing work start times along the x-axis, and then it's mapping out the ratio of work start times based on different races and ethnicities. That's the graph on the left, and then different socioeconomic statuses, and that's the graph on the right. And you can see quite clearly that minorities, and Blacks in particular, and those of lower socioeconomic status are most likely to be working night shifts and non-traditional work hours. Looking a little deeper into socioeconomic status, how does education level factor into sleep health, and does that vary by race or ethnicity? So there was a group that was looking at data from the National Health Interview Survey, and they were specifically looking at differences in self-reported sleep duration and sleep quality by level of education attainment and race and ethnicity. The darkest gray bars represent the lowest level of education in these graphs, meaning that the individuals didn't complete high school, where the lightest bars are representing the highest levels of education, which would be college education or higher. You might expect that higher levels of education would be associated with overall better sleep quality across the board. But interestingly, among Blacks and Hispanics, they actually observed shortest sleep duration in those who were highly educated. But in whites who are just as highly educated, they were able to get more sufficient sleep. Additionally, trends towards more insomnia symptoms, so difficulty falling asleep and staying asleep, were highest among whites, regardless of education. So this was another study that was done in Ohio, and it was investigating if sleep health and mental health were disproportionately affected among those of low socioeconomic status. They surveyed a little over 15,000 residents in Ohio, and this was across over 1,000 zip codes. And they did this through telephone interviewing, and this was during the COVID pandemic. They calculated the participants' social deprivation index using their zip codes, household income, education levels, housing situation, meaning whether they rented or owned their property, and whether it was a single family or multifamily unit, certain household characteristics, like whether it was a single parent household and whether they had dependents under 18 years of age, what the transportation means were, if they owned a car or not, and what the employment status was, so the percent that were non-employed adults under 65 years of age. So they took all of that information, and then based on that, they were able to divide the participants into 4 quartiles of socioeconomic status, with quartile 1 being the highest socioeconomic status and quartile 4 being the lowest socioeconomic status. And you can see here that they found that the prevalence of both short sleep duration and poor mental health were significantly increased as socioeconomic status declined. And so another likely major contributor to, sorry, one sec. There we go, lost the lighting. Another likely major contributor to why minorities and those of low socioeconomic status have significantly worse sleep health might be the neighborhood that they live in their external environment. Unfortunately, despite the Fair Housing Act in 1968, there's actually still significant residential segregation within large cities to this day. While these trends over the last several decades have shown reductions in residential segregation, there is still a disproportionate amount of certain races and ethnicities that live within certain neighborhoods across US cities. Now, how does this potentially contribute to sleep health disparities? Well, residential segregation creates the potential for specific populations to be exposed to certain environmental features that might negatively impact sleep. One really interesting example of this that has been studied is the effect of outdoor neighborhood light on sleep. Now, to put this into context, the average single street light emits about 5 lux of light. And the average shopping mall parking lot at night would emit somewhere around 50 lux of light. Sunlight can be anywhere from 10,000 to 100,000 lux, depending on the cloud exposure. And most data supports that exposure to around 100 lux or so can impair melatonin secretion and reduce sleepiness at bedtime. So we wouldn't necessarily expect that outdoor neighborhood lighting would be that impactful on one's sleep. This was an observational study of nearly 20,000 Americans across 15 states. They used nighttime light emission from satellite data and geolocation to estimate individuals' nighttime light exposure. They surveyed participants over the phone and asked them about their sleep habits, things like sleep duration, sleep onset latency, wake after sleep onset, their sleep environment, how much outside light they perceived, if there was outside noise, light within the bedroom, and then their screen time before bed, and then other factors that might be related to sleep, like their bed comfort, household situation, and then population density of the city they lived in. What they found was that the highest artificial neighborhood light exposure was associated with reduced sleep duration, that's shown in the graph on the left, and then also was associated with delayed sleep onset, which is shown in the graph on the right. And there were also reports of increased daytime sleepiness and overall sleep dissatisfaction in people who lived in areas with highest artificial neighborhood light. Interestingly, these associations remained intact even after the authors controlled for possible confounders, such as light within the bedroom, screen time before bed, and then external noise coming from traffic or busy intersections. The authors proposed that the increased artificial neighborhood light exposure might be enough to be suppressing melatonin secretion and causing significant sleep disruption. And so where someone lives could have potentially a huge impact on their sleep health. Another example of neighborhood environmental factors that has been studied is the air quality and its potential effects on sleep. There's actually been some groups that have found links between air pollution and OSA prevalence. So this data comes from a retrospective cohort study, again using the MESA sleep cohort, where they pre-selected patients who had already been diagnosed with OSA based on PSG. They were then able to retrospectively estimate the individual air pollution exposure, specifically looking at particulate matter and carbon dioxide level or nitrogen dioxide levels. And they did this by taking data from a national air quality monitoring system, and then they integrated specific geographic data, including the person's residential location, roadway proximity, population density, vegetative index, industrial pollution sources, and land use. And what they found was that people who were living in areas with increased nitrogen dioxide exposure over 1 year was associated with 39% increased odds of developing moderate to severe OSA, while living in an area with increased particulate matter exposure over 1 year was associated with a 60% increased odds of developing moderate to severe OSA. They also looked to see if there was any relationship between the sleep quality and air pollution, but they didn't find any significant associations. A possible mechanism for air pollution levels contributing to development of sleep apnea could be through upper airway irritation, edema, and subsequent narrowing. What was interesting is that when they did the pollution exposure and calculated over a 5-year duration, the same effects were not as strong and certainly hadn't exponentially increased. So it's thought that maybe there could be chronic adaptations of the upper airway that can occur with long-time exposure. And so again, where someone lives can have a huge impact on their sleep health. So further exploring sleep and mental health, how does racial discrimination factor in, if at all? There are some unique sources of stress in underrepresented minorities that we might not always be aware of. Things like psychosocial trauma, microaggressions, implicit biases, systemic racism, discrimination, need for increased vigilance, and residing in areas of low social cohesion and low senses of community. This graphic comes from a longitudinal study of underrepresented minorities who are entering college. The authors wanted to investigate if there was a relationship between racial discrimination and the sleep quality. You can see from all of the arrows here that there's definitely a relationship, and that relationship is quite complex. They found that in these college minorities, both anticipated and experienced racial discriminations were strongly associated with increased levels of anxiety, stress, and poor sleep quality, specifically the emergence of insomnia symptoms like difficulty falling asleep and staying asleep. What was really interesting is that these authors also found that the poor quality sleep were those who experienced poor quality sleep were more likely to experience discrimination. And the study was one of the first to highlight that there's a bidirectional relationship between sleep, mental health, and racial discrimination. And finally, the last sleep health disparity that I wanted to address is one that's observed in those diagnosed with sleep apnea. So there's been a lot of studies that have shown that there's an increased adjusted odds ratio of OSA syndrome in Blacks compared to whites, and that when OSA is diagnosed in non-white populations, it tends to be more severe with a mean AHI around 35 and associated with increased disease-related mortality. This highlights the possibility that OSA is significantly underdiagnosed in non-white populations, perhaps due to lack of appropriate screening, and that only when those populations have developed moderate to severe and/or symptomatic disease are they more likely to be identified. Access to healthcare and health insurance, which could be more limited in non-white populations, could also explain some of these trends in increased OSA mortality that have been observed in the literature. A lot of investigation has gone into some of the reasons behind those racial disparities in sleep apnea. So I mentioned lack of screening and underdiagnosis. It could be by PCPs in part due to lack of resources, lack of time, or lack of training. For those who do get a referral to sleep medicine, studies have found there's relatively high no-show rates to those initial consultations. One study in particular found that of the 421 Black adults that they studied who were referred by their PCP for a valiant of OSA, only 38% actually went to their consultation appointment, but of those who did go, 91% were diagnosed with sleep apnea. The reasons for high no-show rates could be a lot of things. It could be mistrust in the medical system. It could be accessibility to the appointment, like someone's unable to miss work or they have a transportation barrier. Could be that there's competing burdens or other life stressors that seem more pressing, or the individual might have a total lack of symptoms, and they could be of the mentality that because they perceive that their sleep is fine, that they therefore don't have a sleep disorder and don't need a consultation. Interestingly, there's been additional studies that have also looked at CPAP adherence in those with sleep apnea and found that adherence among Blacks was actually significantly lower than among whites. They found 21% adherence in Blacks versus 45% adherence in whites. And the reasons for the lower PAP adherence have been speculated to do with overall poor sleep quality, meaning that they have shorter sleep duration, more irregular sleep patterns, more likely to be working shift work, things like that. Okay, so coming back to this model that we looked at a little bit earlier, hopefully we now understand the multiple dimensions of sleep health, the impact that sleep health has on overall health, the sleep disparities that are observed within the US, and how sleep health on the individual level is heavily impacted by factors occurring at the population level, whether that be geographic location, socioeconomic status, race and ethnicity, home environment, neighborhood or community factors, or cultural beliefs about sleep medicine and the medical system. So now comes the really difficult part of the discussion, and that's with all of this information, how can we as the sleep specialists integrate this into being able to provide better care for our patients? Are there ways that we can implement positive changes at the population level to improve sleep health of large groups of patients? And can we increase our encatchment area and accessibility? So many of the social and societal factors that influence sleep health and contribute to sleep health disparities are difficult for us to address as individuals. Implementing policies to eliminate residential segregation and diversify neighborhoods and improve geographic features would likely yield tremendous benefits to sleep health across the population, but that is kind of beyond our reach as the individual providers. What we can do certainly is to be strong advocates for our patients, to acknowledge these disparities and our own implicit biases and continue to raise awareness. When we see individual patients who have insufficient sleep or insomnia, for example, the standard sleep hygiene practices that we often recommend can be helpful, but might not always be applicable due to the external circumstances. Unfortunately, there's limited data and resources that explore how to effectively provide targeted behavioral interventions to improve sleep in disadvantaged populations. However, there's at least growing recognition that our approaches need to be more contextually appropriate and that we should be considering things like chronic stress levels, traumas, and adverse sleeping environments when we're giving recommendations to our patients. There have been surveys of underserved populations, and they have expressed overwhelmingly great interest in their sleep health and improving the quality of their sleep. But the general consensus is that they are lacking the education and the resources to do so. So one small study in Florida did implement a yoga and sleep hygiene program for those who lived in an affordable housing community. What they did was they offered a 6-week intervention that consisted of 1-hour group-based sleep hygiene education that was led by a behavioral sleep psychologist, 15-minute individual phone coaching sessions by the same provider, and then weekly 1-hour beginner level group yoga classes that focused on deep breathing and relaxation techniques. Only 23 people enrolled in this program. The majority of participants were women that identified as non-white, either Black or Hispanic, and all of them had lived in the same affordable housing community. The group education sessions and the yoga classes were done in one of their community rooms. They did find that there was improvement in self-reported sleep duration from about 5.5 hours before the study to nearly 7 hours per night by the end of the study, as well as subjective improvements in sleep satisfaction. So this does tell us that there is potentially an opportunity to improve sleep health in disadvantaged communities through targeted group therapy. Building on that concept of targeted group therapy, what about digital CBT? Is there a way that we can use a large digital platform and target it towards specific populations? Again, there hasn't been much research on this topic. Cognitive behavioral therapy is, as we know, the recommended first-line therapy for chronic insomnia. And we know that chronic insomnia is highly prevalent among those of lower socioeconomic status and certain racial and ethnic groups. The cost of CBT is typically about $200 to $300 per session, and recommended programs have anywhere from 8 to 12 sessions, which means that patients are paying anywhere from $2,000 to $4,000 for treatment, and this is usually not covered by insurance. So CBT is cost prohibitive to the vast majority of patients, even though CBT for insomnia has been shown to be overall cost effective compared to no CBT when we account for things with regards to both the direct and indirect costs of insomnia. So if you factor in the costs of sedative hypnotic prescriptions, the lost productivity, increased healthcare utilization, insomnia-related depression, alcohol use, and car accidents, then CBT is technically more cost effective than no CBT. So in recent years, digital CBT has come into favor. The benefits of this are that it has the potential for a larger catchment area and is markedly more easily accessible and much cheaper. So typically most programs will be somewhere around $100 to $200, and that'll be covered for a 6 to 12 week online course. Problem with digital CBT is that there certainly can be technical issues. There's overall low adherence. One needs to be highly motivated to complete the program, and oftentimes it can provide an overgeneralized approach. So to that regard, there was some interesting work that was done in China, and it was looking at culturally appropriate digital CBT. China has a really high reported prevalence of chronic insomnia and a shortage of professional therapists that are available to perform traditional CBT. Because of China's very large population, uneven regional development with both urbanized and rural communities, and areas with different language and dialect, they saw an opportunity to investigate culturally appropriate digital CBT for insomnia. Participants were either assigned to the standard or the customized digital CBT for 6 weeks, and then they were followed after that for 6 months with insomnia severity index scores and sleep diaries. And both of the interventions, the standard and the customized digital CBT, used the same app. So what they found was that what they did specifically is that the standard CBT platform contained all the usual categories of CBT. So there was sleep education, sleep hygiene, stimulus control, relaxation techniques, sleep consolidation strategies. But the customized version had the same categories with specific modifications. So one example that they gave in the paper was that the stimulus control, if someone could not sleep, they were told to get out of bed and then specifically try something like knitting or calligraphy, which are congruent with the Chinese lifestyle. The customized version also addressed specific Chinese cultural beliefs, like something called Ziwu sleep, which is the belief of extreme health benefits of a daily afternoon nap between 11 to 1 p.m. And so they integrated that into the customized version. And what they found here, so the culturally appropriate CBT results are shown on the left graph there. You can see the baseline insomnia severity index, and then that same index at 1, 3, and 6 month follow-ups. And then on the right graph, you see the traditional CBT results. You can see that over the 6 month follow-up period, both groups had reductions in their insomnia severity index and improved sleep quality, but the effects were slightly greater in those with culturally appropriate, customized digital CBT. So it kind of makes you wonder if this concept of using something that's contextually and culturally appropriate with regards to digital CBT, if that could eventually be applied to populations within the US. And you can imagine how much that might improve accessibility and adherence. And so another intervention, and one of the more obvious ways that we can significantly improve accessibility to healthcare would be through the utilization of telehealth visits. And, obviously since COVID, telehealth utilization has drastically increased across all fields of medicine. This data shown here comes from the CDC, and it's based on the National Electronic Health Records Survey. It shows that telehealth is used often by PCPs and specialists, and most are able to provide comparable patient care. The AASM actually released a position paper in 2015 and again in 2021, endorsing the use of telehealth as a means to improve healthcare access in the field of sleep medicine. The benefits of continuing to offer telehealth beyond the COVID pandemic include the ability to provide specialty care to underserved populations that may be in more remote locations or have transportation barriers, or maybe be unable to take a significant time off work to get to an in-person appointment. Oftentimes, it's also more cost-effective to do telehealth rather than a traditional office-based visit. Certain limitations of telehealth include that there's a digital divide and that internet access and electronic devices are not always readily available, especially to those of lower socioeconomic status. Any language barriers could be exacerbated during telehealth encounters and make it more challenging. And the experience potentially could be felt as dissociative and off-putting for some individuals. They might feel the difficulty in connecting with their provider over telehealth. And finally, not everyone is technologically savvy, which is especially true of older adults. So telehealth does have its limitations as well. Okay, so I apologize. I'm about to bring up a specific company, which I'm not sure if that's allowed, but I don't have any affiliations with them. And I just came across them in my research, and I think what they're doing is really cool and worth mentioning. So there's this nonprofit group, it's called Project Echo, and they originated from the University of New Mexico. Their mission is to improve healthcare access to underserved populations. They started in 2003, and they initially were developed to provide access to specialty care for treatment of advanced liver disease and hepatitis C in extremely rural communities. The problem that they were facing was that the treatment was expensive and the clinics were very far to the patients. And so what they did was they created this online virtual platform where they were enrolling PCPs to participate in case-based learning and guided clinical practice in order to co-manage these complex liver patients who otherwise didn't have the resources to get to a specialist. The reason I bring this up is because they rather recently launched a sleep medicine tele-mentorship program for VA PCPs. And this was in order to be better equipped to co-manage common sleep complaints. They called it the Sleep VA Echo program. They did was they enrolled PCPs so far have reported numerous benefits from the program, including improved quality of care for their patients, expanded skill sets in managing sleep issues, and an increased sense of community. They reported the greatest benefit in their clinical practice was with regards to patient education and behavioral management of insomnia, and a slightly lesser benefit in sleep apnea care. Since we have a shortage of sleep specialists, and oftentimes the wait to be seen as a new patient can be several months, this type of model could potentially empower PCPs, PAs, APRNs to manage a significant portion of sleep complaints like PAP adherence, insufficient sleep, insomnia, and even co-manage more complex cases, which would ultimately drastically increase the number of available providers and the accessibility for underserved populations. Another potential option that we can consider is a more proactive approach to screening, especially important in conditions like sleep apnea that can go undiagnosed in certain unrepresented populations. One way that we could do this would be approaching high-risk individuals during their hospitalizations, which would allow us to look for people who might not otherwise seek out medical attention or get a referral to a sleep center. There was one large multi-center study that looked at the feasibility of doing exactly that. They screened over 1,200 obese Black hospitalized patients via stop bang, and if their screening was positive, they were offered a type 3 portable monitoring to assess for sleep disordered breathing. And if that was positive, they were recommended for a formal outpatient PSG for confirmation on discharge. They found that 63% of the people they screened positive for sleep apnea agreed to go further testing. And of those who were tested, 60% were found to have some form of sleep disordered breathing. But the problem was that only 10% actually followed up in the outpatient setting. Another way that we could potentially improve screening for sleep apnea in underserved populations could be through the emergence of all of these smartphone apps. So it's estimated that there's nearly 100 different apps available for download right now that claim to either promote better sleep or maybe screen for some kind of sleep pathology. But the problem is that these are unregulated direct-to-consumer products, and the majority have not been studied or validated. There was a recent systematic review that looked into this and found that only 10 smartphone sleep apps have some kind of scientific backing in the literature. Several were marketed to measure sleep stages, sleep efficiency, sleep onset latency. However, when they looked at the corresponding PSG data, they found poor correlation and accuracy. And so AASM did release a statement in 2018 citing these limitations, ultimately suggesting that sleep consumer technology can be utilized to enhance the patient-clinician interactions, but at this time cannot be used in place of traditional testing. But now, with the release of WatchPad and other diagnostic wearables, it really seems like only a matter of time until there may be some kind of accurate sleep consumer product that becomes available, which would have the potential to drastically improve accessibility to screening. The last potential intervention that I wanted to touch upon has to do with the concept of a buddy system. There's actually been great success with this in the worlds of HIV, heart failure, and diabetes care with regards to medication adherence rates when buddy systems are implemented. And so more recently, some have been looking into the use of a peer buddy system for improving CPAP adherence. So they took some patients who had newly diagnosed sleep apnea, and they were randomized either to the usual CPAP care versus CPAP and the buddy system. The buddy system involved pairing the newly diagnosed subject to a peer who was already adherent to CPAP therapy. They studied these groups of people over 3 months. Essentially, the program entailed that the peer and the buddy had 10 interactions, some were in person, some were over the phone, where the adherent peer essentially shared their experiences. So things like mask fitting, machine upkeep, basic troubleshooting, and then if applicable, they shared the improvements in their quality of life and overall health that they might have observed since they started CPAP. What they found was that the CPAP adherence in the peer group was 5.2 hours plus or minus 2 hours compared to 4 hours plus or minus 2.4 hours in the control group. And so although statistically they didn't reach significance, clinically these are really nice results with the buddy system. And a system like this may be particularly impactful when we think about underrepresented minorities who struggle with CPAP adherence. They may actually benefit greatly in learning from their peers, though this has not yet been studied. And so, in summary, sleep health is very complicated and multifaceted, and education and awareness in sleep health is lacking, both in the community and among healthcare providers. There are significant socioeconomic, environmental, and racial and ethnic disparities within sleep medicine that have impacts on insufficient sleep, insomnia, and sleep apnea. Opportunities to reduce sleep health disparities include things like proactive screening of common sleep disorders, targeted individual and group therapies that are both culturally and contextually appropriate, which includes things like sleep education, sleep hygiene, and maybe even digital CBT, telehealth and telementoring programs, the peer buddy system, and then just working continuously on patient advocacy, raising awareness and education, and working on our own implicit biases. I'll end with saying that for anyone who's interested in learning a little bit more about their own implicit biases, Harvard University has this website called Project Implicit that allows us to take various implicit association tests. It's really, really interesting, and I highly recommend that you check it out. These are my references, and thank you so much for listening. I am happy to try and answer any questions.
All right, fantastic, Dr. Lindo. That was just an amazing discussion. And we have a comment from Dr. Yagi. Great talk. It was nice to have in addition to talking about disparities, pairing it with potential interventions. So Dr. Bakhtiar says, excellent talk, Amanda. Impressive.
Thank you.
So feel free, if you, we have about 33 people on the call, so you can certainly unmute yourself and ask a question, or if you want to put something in the chat, that's great as well. I'll start off by just giving a sort of a comment and question. I think you made a great case for using population health, especially in sort of populations that are at risk. You know, a lot of these interventions, such as like CBT, digital, there's some costs associated with that, and there seems to be, you know, like some for-profit companies that are more, you know, profit oriented. Has there been any sort of countries such as, you know, that have a universal healthcare, such as England, Canada? Has there been any, you know, examples where they kind of support some of these platforms?
Yeah, so there was some literature stemming from England, and they were essentially looking to have like a universally available digital CBT, and to see whether essentially if it was cost effective or not when applied to the masses. And they did, I forget the specific numbers, but there was a slight per person cost reduction. And then when they did a couple calculation models and sort of extrapolated that data over both that specific region in England and then across the whole UK, they found marked healthcare savings. And so the authors were kind of sort of speculating and thinking about how that could potentially be integrated into more usual care in the future.
Right. Yeah, I definitely feel like there's a lot of opportunity for these sort of population-based things. So fantastic. So Dr. Bam said, great talk, Dr. Lindo. Thank you, Dr. Bam. Thanks for a very timely and meaningful talk. How these interventions target cultural differences, such as in language or traditions. So I don't know if you give an example of some of you know, sort of targeted interventions based on cultural differences in language and tradition.
Well, I mean, the two that I kind of mentioned that I think are relevant would be, one was that peer buddy system, which was specifically with regards to CPAP adherence, but the potential to peer a patient with a newly diagnosed issue with a peer that is similar to them and that they can, you know, really associate and bond with, might have the potential to be really impactful with regards to targeting therapy more effectively. And then the other thing was, you know, with the concept of digital CBT and how much changes and improvements we see within technology. And so being able to target technology to the individual rather than just providing a generalized approach and not considering someone's whole picture.
Yeah, I think that's, you know, a great point. I mean, it just seems like there's so much potential opportunity for researchers to get NIH grants to do this, to sort of target at-risk populations with, you know, sort of, you know, rather than run-of-the-mill sort of interventions. And it seems like it just has such a great potential to be used. I would love to hopefully inspire someone on this call who's into that type of research and make it more commercially available so it can have some practical application. So fantastic. And then your co-fellow, Dr. Deng, says an amazing talk. So
thank you, Chloe.
All right. Anyone else have any questions? I know we have a great state chest conference. I want to make sure everyone has time to get there. But any other last comments, questions before we conclude? Okay. All right. Thank you, everyone. Appreciate everyone's time. Have a great weekend.